I'm opening up the session for questions, and since we are the chairpersons of this conference, I'll start by asking Sai a few questions, and then, of course, I'll ask the person who discussed about Bernard's not on call, which is unfortunate. We would have liked to discuss some of that. So we'll start with Sai. I want to ask you a question. I proctored you. I can see the amount of amazing cases that you have done. Do you think this is going to become the mainstay of treatment of patients with functional mitral regurgitation and LV dysfunction in India?
There's absolutely no doubt about it, Saibal. I still remember 2017, November 2018, when you came, and I remember you telling that this is transformational therapy, and I could not comprehend what it meant until I started taking these patients. We've done over 110 cases so far. And if you pick your patients right, it's like waving a magic wand. This therapy is here to stay, in my opinion. For India, absolutely.
Dr. Shivanta Mukherjee, do you have anything to say about the same thing?
I would definitely agree that for secondary cases, H2H repair is a wonderful technology, particularly with no other significant options at the present time. With regards to, I would say, if we think about having other options, once the valve replacements, if they come into with the data that there is a significant benefit and the procedure becomes more straightforward, we have got more ability to tackle the LVOT obstruction risk, then they might have an edge just because with regards to complete elimination of MR. But again, in secondary, complete elimination of MR, even sometimes when we see that when we have got extraordinary good results with H2H repair, the ventricle sometimes lags behind. It just cannot tolerate that immediate afterload mismatch of having no MR versus a torrential MR. They are the patients who require a bit more hospital stay rather than going out on the next day because their LV needs a bit of push. But definitely at present, I think H2H repair has given us that extra weapon in our armamentarium to treat these patients. And we have had very good results at our institute in treating patients who were bad LV, severe MR, no other options, maximized on their medical therapy, having CRT, despite that not doing well. H2H repair has been very helpful. But again, there is a word of caution that not all patients, because technically we are taking on more and more challenging cases, but we just need to be careful about selecting the patients, not to, the moment we start getting bad results or, our outcome data, when we audit, if it's not up to the mark, then there comes a question. But it's more related to the patient selection versus the efficacy of the therapy. So that has to be taken into account.
Thank you, Shubhro. There's a question from the panelists. I want to start by, of course, thanking Shubhro for inviting me to this talk. There's a question from the panelists that the mitral valve annulus is a saddle-shaped annulus and is actually dynamic. And trying to treat that with a circular valve may not be physiological. Am I right, Shubhro? Is that the question?
Yep, that's the question. It's here. What are the long-term hemodynamic consequences? The question, mitral valve is a saddle-shaped. Implanting a circular valve is going to change the architecture. What are the long-term hemodynamic consequences of this?
I think this is a great question. I'm happy to answer this question. Really? I think people have always asked me, I spoke on TMVR today, but I can tell you one thing. People have asked me, what is the best bioprosthetic valve in the mitral position of all the valves that you've seen? I said, the best one is your own valve. So when you have it, you should try to preserve it. Absolutely. Mitral valve is not even a valve. The mitral valve is an apparatus consisting of annulus, leaflets, cords, papillary muscles, and the ventricle. And just replacing this apparatus by a stiff nitinol cage cannot be completely physiological. And of course, trying to preserve it by any techniques, whether it be annuloplasty, whether it be clips, with the rings, whatever it is, makes more sense and I think has long-term human, as we've shown in the QUAC trial. Having said that, there are a group of patients which cannot be repaired. And those which cannot be repaired, there has to be a solution for one that's for TMVR. And so I rightfully agree with your comment that the mitral valve, if you can repair it, you always repair it, and whether it be secondary MR or whether it be primary MR, both. I personally think that in secondary MR, I'm biased, that in secondary mitral regurgitation, especially with very low ejection fractions, less than 25%, I don't think a TMVR is a great solution for very low ejection fraction, even transeptals. I'm a little biased about that. Yeah.
Saibal, I want you to just answer one more question, which I know that, every patient I put a clip in, 80% of my 75 to 80% of my volume so far is FMRs. The surgical colleagues of mine and so many of the cardiologists always ask me, when the Alfieri stitch doesn't work, how does this clip work so beautifully? And I tell them, look, it's because of the less physical trauma to the patient. But I want your perspective, Dr. Mukhopadhyay, please feel free to jump in. Why is it when the Alfieri stitch didn't work, why is it that a similar principle works so beautifully?
So there are some, even though the MitraClip or even Pascal are based on the Alfieri stitch, there are some dissimilarities. Number one, the MitraClip, first of all, you can accurately place the clip where the MR is most severe because you're doing it on real-time echo. So you can actually place it where it is leaking the most. Two is that you deal with a nice vertical coaptation of the leaflets because there's a length of the clip, right? 6 millimeter for the short, 9-10 millimeters for the longer clip. So you create a vertical coaptation of leaflets, and we do know that creation of vertical coaptation of leaflets is helpful. And third, if you do a broadband, now without an annuloplasty, if you did not do an annuloplasty, we've still shown good data, right? I still think that if we did have an annuloplasty, maybe it would have been even better, right? We don't know that because we just know the data is good with the clip. But if we did have an annuloplasty, we probably would have had even more durability. I can't say that correctly because we don't have one, but just because we don't have one, we can't say it won't work, right? So I do think it works for functional. Remember, in functional MR, the leaflets are normal. The leaflets have no problem. It's a malcoaptation at the level of the leaflet tips because there's scarring of a papillary muscle pulling one leaflet to the other. So it does make sense for this to work. And I don't think the surgeons used it very often for functional MR. They used rings. I think if they did use it with a ring, it would have been good. But for DMR, because that's even though this is a heart failure question, is for degenerative MR. So I think most of you, Shumant, you agree with this, that the co-op data showed that irrespective of the surgical risk, for secondary MR in a patient who's got adequate medical treatment, this should be the first line of treatment, right?
Absolutely. Absolutely.
And the mortality curves are pretty amazing with this study. Now, the second part of the questions are and then I'm going to go to tricuspid. Before I go to tricuspid, our second part of the question is for primary MR, degenerative MR. So we do have an indication right now for patients who are high surgical risk patients, correct? Yep. Who are patients they have no surgical options and the treatment is to repair the valve. Two questions. One is, if for this group of patients, TEER is recommended, right?
Yep.
But would you consider, let's say you get a patient who's 80 years old, who's got a flail P2, and you have two options in your hospital. You can do a MitraClip or a Pascal, or you can do a TMVR. Which one would you choose?
So if it's a flail P2 and like in the middle of the valve, you got a definite, target, I would still choose an edge-to-edge repair because this is what we do and we get excellent results. Like we kind of challenge our surgeons by saying that we will get surgical results and we get that, and the patients do like their remarkable experience and their functional class improves, and we see very good and sustainable results as well because we've been doing it for a few years now. So I would definitely go for, It's for us still TMVR consideration is where we have a very commissional flail where it's unlikely that you would get into there. The risks, technical risks might be quite high. In those cases, we do evaluate them for evoke, which we are our M3, the encircle trial, which we recruit them into. Those are the patients. But if it's a P2, even I would say P2 extending into P3 or extending into P1, we'll still go for an H2H repair because this is what we have like significant experience and we get amazing results.
Good. Sai, what do you think? Same thing? Same question?
Absolutely, Saibal. So, if I answer this question, like how I'm going to answer today, 4 years back, I would have been beaten by my surgeons because a lot of my colleagues, we have very good surgeons here. So that's the challenge, And what they come to me say, they say, Sai, listen, this is a healthy guy who's a good surgical candidate. If I do a repair, that's the last he'll see me for the rest of his life. Why do you want to go put a clip in him? I still feel that if your surgeon can do a great repair, maybe the patient is better off with the repair. I still feel that a surgical repair, if he's a good surgical candidate, I would still give him the option of getting a repair. My problem comes if they go in, find too much tissue and replace the valve, then I feel miserable. The second kind of cases that I would think very, very long and hard before putting a clip in is the Barlow's with the excessive tissue, because we have done some of these. They look great when you put the clips in, then they wobble a little, you put a second clip in, then both the clips wobble. And then they do great with trace MR, but they always come back 3 years later with a jet somewhere else. So I don't know, you guys have more experience. What do you think?
Well, you're right. I mean, I think that complex degenerative mitral regurgitations are best solved surgically. So that brings me to a very interesting question since you brought up both. I brought in the example of 80 years old, okay? Now, I'm going to put two scenarios, okay? One's a 60-year-old man and one's a 76-year-old man, okay? Both have flail P2s. And both of you can say, I can fix it great by surgery and great by repair, surgical repair. What would you do for the 60-year-old man? What would you do for the 75-year-old person?
Well, for the 60-year-old, at present, our guidelines does not let us do. So it's
no, even if the guidelines are not, the patient is a multimillionaire, he can pay for anything he wants. What would you do the right word as a doctor?
For 60, I would say, and probably surgery is the option, just because it's got long duration, long durability results. We know from like previous reports and the evidence that surgery has good long-term outcomes. Now, 76 is a very controversial area. So this patient would ideally go to an MDT, and whereby we would evaluate other causes. And if there is even slightly higher risk, if the surgeon says that, okay, this might be a possibility, that might be a possibility, or I might need to replace the valve, then I'll still consider an H2H repair at that moment, because having an H2H repair does not preclude him for having a further surgery. It might not be possible to repair it, but if the surgeon says like, oh, I'll try to repair, and then he goes for a replacement, why not I try to repair and then you go for the replacement? So in case, but if it's a very kind of, it's like 76 also straightforward, might be going for it.
Do you agree with the side? Do you agree with that answer? Or anybody?
In my center, 76 will be no brainer because the 76 Indians are a lot
framer. We know. When I say 76, I meant relatively. I meant 76 is equal to 80, and that is true. But 60 would be considered, right? So the reason why I brought this question up, which is very good, and I like the answers, there are two clinical trials going on, randomizing MitraClip versus surgical repair, right? So it seems like you had an equipoise on the 76-year-old man, correct? But definitely not a 60-year-old person, correct? So therefore, you would think it's unethical to randomize a 60-year-old person to surgical repair versus MitraClip if he's healthy, correct?
I wouldn't do that, but I have a point. I would still offer the 60-year-old a clip. I would offer the 60.
You could, but do you think it's all right?
Okay,
Did you-
it's a 50-year-old. I would think it's unethical to randomize it. Yes,
60 is 60 you think is randomizable.
I think so.
And 75,
I
Sumanta?
would just
I would say based on our practice here, it's 60 is a surgical. It's not ethical to randomize that patient. 75.
75, 70, 76? 76?
76, yeah, it's good enough to randomize. And probably if, having a data would help us to drive it towards more low risk and younger patients. Like I think all the trials of TAVI have been phenomenal, and the success of it has been phenomenal because just, treating high risk, coming down, low risk, moderate risk, low risk, moderate aortic stenosis. So if a technology comes into play or comes in where it is suited and safe for high risk elderly individuals, then gradually it will succeed and get more acceptability.
So you just from summary from both your comments, it seems like both of you agree that randomizing a person where there's equipoise is the right thing to do, correct? Is a reasonable thing to do. But randomizing a patient where you don't have data and the patient is low risk is not ethical, correct? Unless you get data for moderate risk, right? You would like to
Yeah.
go stay
Yeah,
high.
I would take a safer approach, and the way I would
Reason
agree.
I'm bringing this up, I'm the national PI of the Repair MR trial, which randomizes 75 and older. And there's another study called Primary MR, which I think is unethical, which is trying to enroll low risk patients in the intent to show surgery is better than clip, which I think is so wrong to randomize this patient, right? How do you walk up to a patient and randomize this patient? So that's my point. Now let's go with a few minutes left. We have 8 to talk about tricuspid.
And I just switch in one question. I would want to know what your views are with regards to in patients where you have had previous surgical, repair, particularly with regards to this neocords and had an annuloplasty ring, and then come back with the severe mitral regurgitation. What would be your like assessment or your modality of treating? Would you still go for an edge-to-edge repair, or if you find there is a ring which is suitable for an implantable, the valve systems that we have, either Sapien or even I think in India, MyValve. So would you go for the valve or would you go for an edge-to-edge repair? And what will be your considerations?
I was involved in the mitral valve study, which is the mitral valve ring. I've of course done a lot of cases of previous surgical repair failed with clip. My always first possibility is to try to repair it, if possible. So if it's an isolated flail, I try to do it. If it's a commercial flail, I try to do it. But sometimes you just can't do it, and then it comes to TMVR in ring versus redo surgery. TMVR ring is not always easy, by the way, because there's a higher chance of LVOT obstruction. There's a higher chance of perivalvular leaks. I remember I had one with several perivalvular leaks with the ring was elliptical. But it's going further, I still try to repair. But I've done quite a few cases of surgical repair following failed, mitral failure. The key in that is the size of the ring that the surgeon put in and how much the leaflet was excised. If the surgeon didn't excise much of leaflets and just put artificial cords, those are perfect cases.
Yeah.
But if the surgeon has incurred a lot of tissue, then it becomes quite challenging to repair, do the clip. That was a very good question, by the way. Going to that, next point is tricuspid. Okay. Now that's become a hot topic now. And you already have seen the Triluminate data, which I was steering committee member. And you will also see the TriSend data coming up in the next month. Okay. Now, in the tricuspid space, as you rightly said, most cases are secondary function tricuspid. Okay. Now, if you had an option if you compare the two, and you've seen Evoke, it's actually quite good. Now, if you have and you've seen the data of a trial, it showed no mortality benefit at 1 year, no hospitalizations different 1 year, but there was a clinical improvement of symptoms, correct? You can agree there's many placebo. There was a clinical improvement of quality of life. based on this data that you have right now, and the safety was very good, right?
Yeah.
No heart blocks, no thrombosis, no deaths.
Yeah.
Would you approve this device and say you're on the FDA panel and they ask you, would you approve this device? And I'll tell you the questions that are asked in the FDA. The FDA asked 3 questions. Number one, does the data support the safetiness of the procedure? Okay. Does the device support the effectiveness of this procedure? Yes or no?
So safety, definitely yes. Now, effectiveness, I would say, is if you come to hard endpoints, it hasn't met the hard endpoints.
Mhm.
But I think there is many of these patients who are being considered for edge-to-edge repair at the present time for the tricuspids. For us, we see that they are long gone, like in the sense, their RV is quite bad. They're just struggling. So we know their life years are limited. So now improving the quality of life is also an important feature of these kind of patients. And at present, these are the patients where we kind of offer, yeah, definitely we should, like if he's functionally well and struggling with the symptoms, okay, can we do something to make him better with his day-to-day life? So I would say there is some effectiveness of the procedure, but rest of the effectiveness we haven't been able to prove yet. But with more data, more patients being enrolled into, and
So my question to you, yes or no? With the present
Okay.
data at 1 year, do you think it was effective in your eyes or not?
I would say it is partially effective. I won't commit to it completely.
What about you, Sai?
Tricuspid,
Second
I'm going to
question.
punch out and say,
Safety, you've gone through it. Second question, effective. And the third question will be the risk benefit. So do you think this data supports the effectiveness of this therapy? That's my question. Only this data. You don't have to say your personal experience or anything like that.
Yeah, I would
I
say
think
this. Sorry, go ahead, Sai.
That's what the
No,
panel
no,
is. The panel is
I-
asked this question. I'm acting as the FDA commissioner, and this is what they say. Dr. Sai, based on this data, do you think it's safe?
Yes.
And then you think it was effective?
Yes, but that's such a difficult. Yes.
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 Okay. The
Yes.
third question will be, based on this data, does the risk benefit ratio support the indication for this procedure for high risk patients?
Yes.
For this one, I would say yes. The reason being, the risk of this procedure is virtually negligible.
Okay.
So risk benefit ratio, where if we compare to, there is a definite benefit in terms of functionality and the symptom class. So risk benefit ratio would be in favor.
Okay, and you, Sai?
What do you think? Did you agree with what I said? I think definitely risk benefit ratio, considering it's safe and these patients are miserably ill, and I feel we have nothing to lose. There's nothing else in this space right now. That's how
Okay.
I look at it.
Good. We need you in the panel. So here's a story, because this is very important, because this is what the FDA says. So the reason why this is important is that Sean showed a very new slide about mortality with tricuspid. Remember? You showed the different degrees of TR associated mortality. So the FDA is saying, hey, wait a second. You guys were showing TR causes mortality, and then you did a TR and you showed no mortality benefit. What the hell is going on? You got it? So this is the reason why this question is relevant. And it is true for these patients do very well. I was in the trial, they do very well. But this is a question and answer that many people, like Shubro as a heart failure person, will say, hey, wait a second. You didn't show any admission of heart failure. There are 2 things about it in the trial which I have a personal thing about. Number one is, we may have taken people too early in the disease, or as you rightly said, we may have taken patients too late in the disease, right? And so we never could show the hard endpoints. And the second is, right heart failure symptoms are very different from left heart symptoms, right? Left heart presents with acute heart failure, pulmonary edema, and hospitalizations. Right heart failure people are edema, swelling, and impairments, which don't happen. So I think the time has come to end this wonderful session. And I would like to thank all the speakers who answered so great, and the audience and the as well as the chair people and the organizers. Shubhra, thank you very much for. Do you have a question? You.
Thank you. Thank you for being bang on time.